Hi everyone. Hello. Hopefully everyone is good, happy and healthy. I'm so happy and excited tonight. I have a very special guest and can't wait to introduce him to you. Dr. Alan Christensen, expert and renowned doctor, naturopathic doctor, endocrinologist, and expertise in thyroid disease. So it's a special night, and I'm going to invite him to join us. Make sure that you write any questions you have. And I received some questions that I'm going to share with him. And thereafter, if we had a chance to go through your questions, it would be great. So let me know where you're from, and I'm going to invite Dr. Alan now. Hi everyone, good to see you. You can either type here in the comment or in the question box if you have any questions. Good to see you all. Hi, Dr. Alan. Okay, let's see. I'm inviting. Hi everyone. Hi Helena. Accepting. There is always some technical problems in the beginning, so bear with us. And I'm accepting. And again. Oh, hi.
There we go. Hey, how are you?
Good to see you.
Good to see you as well. This is going to be fun.
It's pleasure meeting you here. I missed you last month in Vegas at A4M.
Yeah, heard it was a good event.
I even had my book signed.
Oh, that's awesome.
Hopefully next time.
Next time.
So it's great to see you. Thanks I know you're busy and with all your busy schedule to accept and join us here tonight. I'm sure a lot of people have questions, but before diving into questions, would you be kindly enough to introduce yourself, a quick bio?
Sure. Yeah, thanks again for having me. I'm Dr. Alan Christensen, so I'm a naturopathic endocrinologist, a New York Times bestselling author, and it's all about thyroid disease for me. That's been the focus for about 30 years now. So yeah,
amazing.
It's been a lot of fun pulling together what we have from medical literature, from research, natural medicine, conventional medicine, and there's some great facts that make a big difference out there.
Yes, absolutely. So I received some questions. We dive into the first one. So the main question is about diagnostic tests. I myself, as a conventionally trained doctor, GP for many years, we're taught in school to basically do thyroid stimulating hormone, but the last 5 years functional medicine is absolutely different approach. So I'd love to hear your thoughts and recommendations on the tests.
Sure. So we're thinking about thyroid function, thyroid autoimmunity, and thyroid structure. You know, three big things. And if someone is struggling with symptoms, they're trying to explain why, not sure what's going on, the most common thing that's thyroid related that can be a culprit is thyroid autoimmunity. And one of the biggest gaps is that there's just massive bodies of evidence saying that regardless of thyroid function, even if there's no slowdown or speed up, that thyroid autoimmunity causes symptoms. It causes health risks. And we see that by screening for thyroid antibodies. We can talk more about the nuance there, but that's a test that's great to consider for screening. And conventional medicine doesn't do that one.
No, no. TSH only.
Yeah, and TSH is a good test. It's helpful. It's one of the more sensitive gauges of thyroid function. It's actually 50-fold more sensitive than T4 and T3. It's the earliest indicator. So it's a good indicator of thyroid function, but not a good indicator of thyroid immunity. It has no real relevance for that.
Absolutely right. Yes. So then you do thyroid antibody tests, total T4, T3, and free T3 and T4.
There's lots of tests out there. There's a lot of ones that are dated that we don't use anymore. RIA, T7, a lot of obscure things. And there's some subtle differences. So in measuring thyroid output, there's pretty clear consensus that you want to measure T3 and T4. There's different tests available. And the difference between free and bound is whether you're measuring the active hormone or the hormone bound up with the carrier protein. And generally, the active hormone is more meaningful. But when you get to really low concentrations, things that are present in tiny quantities, you start getting to the very edge of accuracy in terms of technology. So free T4 is clearly superior. Free T3, as of late, is argued to be not superior, just because it's such a minuscule thing you're measuring. So in concept, it would be more accurate, but in practicality, it's just hard to measure at that level. And this is a subtle distinction. So yeah, total T3 versus free T3, subtle distinction, but consensus now is on free T4, total T3 for measuring thyroid output.
And then the question again, some people ask is about timing. Does it matter the time of the day? Does it have to be fasting or any time you can do the tests? And do they have to skip medication, thyroid medication, especially supplements, other medications, or is it okay to take them when they're going, or is it going to affect the results?
Yeah, great question. And some context, if someone is just screening their health, they're not sure what's going on, they're not really in the world of tracking thyroid disease, they can get reasonable data without doing it perfectly. But when someone's tracking their thyroid over time and they're titrating medications, they're watching their diet, in those cases, all those points you mentioned can have a big difference upon how their scores look. So yeah, time of day, thyroid hormones are circadian. So like 7 to 9 in the morning is the relative window. Fasting is relevant. When you eat food, that changes it. A lot of supplements can change, not necessarily how hormones work in your body, but how they work in a test tube. So yeah, it's better to take a 3-day holiday from supplements before thyroid tests. You mentioned medications. If someone's on thyroid medications, yeah, there's a window of about 2 to 12 hours after you take a medication where the direct measurement of T3 and T4 is totally unpredictable. Both those hormones are at a lower level before you take them, but they're not at a baseline. So you're still seeing the function of the medication. So yeah, tests before meds. And then lastly, menstruating women. There's a big difference in how a woman's thyroid hormone levels will look from some parts of her cycle versus others. So with day 1 being the first day of a menstrual cycle, days 1 through 9 are fine, and days 20 through 28 are great, but days 10 through 19, pretty unpredictable.
So that's the time that they should not have the test.
No, if you're comparing reading to reading, you can see differences of many points if they're not, if they're within that window in general, or if they're at one window comparing to another.
Ovulation time period, they shouldn't.
Yeah.
That's interesting. Very interesting. What about diagnosis of Hashimoto's disease? Again, a lot of questions and confusion on iodine and your expertise, iodine and diet. So is any way iodine affect Hashimoto's and that antibody levels? Is it important to take, or they should refrain if anyone has positive Hashimoto's disease?
Yeah, such a good question. And we can go back a step and talk about what we measure with Hashimoto's and what's happening. So there's an enzyme and a protein, there's thyroid peroxidase, and then there's thyroglobulin. And these are the structures that are involved with generating thyroid hormones. And these are the things that come under immune attack in Hashimoto's. So thyroid peroxidase, its job is to oxidize iodine. So it converts iodide into iodine. It makes it reactive and makes it want to bind with something. So it's transforming iodine. And then thyroglobulin is the template on which iodine is stored. And that's how we make the hormones. There's like 13 tyrosol residues where iodine should go. But if there's too much, it goes all over the place. And iodine, we think about like hydrogen peroxide or bleach, like strong antiseptics. They make free radicals, and iodine is also an antiseptic. So it makes free radicals. That's how it makes thyroid hormones. But when there's too much, that free radical damage, it harms the structures of the thyroid. And that triggers an immune attack, and the immune system starts to treat the enzyme and the protein as foreign compounds. So yeah, it's a causal part of the onset of thyroid autoimmunity. And I should say, not that we shouldn't talk about it being good or bad. We need some, and we can't live without it. And we get abundant amounts of it in the modern world. We get plenty of it in all sorts of things. But the question is how much? And the further question is, how does that vary per individual? So iodine requirements don't really vary that much other than body size, but iodine tolerance varies tremendously. And there's about 12.5 genes that correlate with all the versions of thyroid disease. Most of those genes are variations on iodine metabolism. Short story, humans evolved in 2 different environments. One environment was close to the oceans, one was far from it. So some humans have mechanisms that are good at doing fine in an abundance of iodine. Those are the folks that live by the ocean. Everybody else often had very little. So they got good at storing every speck. But you can't do both. So now the genes that store every speck can't really tolerate an abundance. And those genes, they can be exposed to amounts that are not harmful for most people, but for them, that can be the trigger for thyroid disease.
Wow, very interesting. This is the first time I hear this story. Very interesting. And now talking about iodine, is there any way to measure? And if there is, what's the best way to measure the levels, or we can't?
Well, there's how accurate, and then there's how clinically relevant. So we can measure it in different compartments of the body, yes, but is that relevant to the amount in the thyroid? And does that really help us know if someone tolerates it or not? Because it's not just how much is there, it's how well you tolerate it. So the question is, can measuring iodine predict who might benefit by controlling their iodine intake? And some of the studies that I cite showing that controlling iodine can reverse thyroid disease, some of those studies did measure participants' iodine levels beforehand, and then looked to see if their levels before predicted how they would respond. They just don't predict that. So yeah, you wouldn't really test and say, oh, my iodine levels are low, therefore this wouldn't help me. No. And then in terms of accuracy of iodine measurements, because it's such a reactive compound, there's honestly no accurate tests for individuals. There's a lot of tests that are great for populations. When you're measuring hundreds of people, the variations just don't really matter at that group level. But for individuals, none are accurate, and that's quite true. The one scenario where I advocate testing is if someone has been regulating their iodine for some time and they're failing to see a response. You can check iodine excretion, and it doesn't show your status, but it could show if there were some hidden sources you're still being exposed to.
So normally we don't do it then in a
it's not predictive
life. It's difficult.
Yeah, blood tests of iodine are the worst. They have no relationship whatsoever with nutritional status. Urinary tests have some relationship, but you got to test people, no exaggeration, hundreds of times to get close to accuracy.
What about hair? I heard some tests on hair as well. Some people do hair measurements of iodine in hair, so I'm not sure again how accurate that is.
Yeah, hair tests have been looked at. Quite simply, no correlation. And then there's also skin tests. You can swab your skin with iodine, and it's the story there is that you can see the color of iodine, and then it goes away after a while. And it could seem intuitive that your body sucks it up when it wants it and leaves it there when it doesn't want it. They did some big studies on that in 1932, and they used cadaver skin, like dead people's skin, and then healthy people, those who are low in iodine. it didn't matter. We don't have teeth in our skin. We can absorb things, but we have no preference or no mechanism to control that in our skin.
True. Yeah. Then, and about now diet and foods for Hashimoto's, so autoimmune disease, thyroid autoimmune disease, how we can lower that antibody levels if there is any way, or what type of diet you recommend and it works.
Yeah. So one thing out of the gate to talk about is we want to think like scientists. We want to ask different questions. So one question is, has anybody ever done diet X and saw their thyroid get better? And that's one question you can put out there. And the answer to that is going to be yes, because there's a good chunk of people that randomly recover from pretty much every condition, and thyroid disease is no exception. So the question is not, did diet X ever help anyone? Or the other question people can ask is there some reason we might think why diet X would help? And honestly, you can make up a reason for anything doing anything. So those two questions I don't find all that interesting. And if someone did diet X and they got better, that's totally cool. Wish you all the best. But when someone comes to me, I want to know what's most likely to work for a given individual. So I want to look at large controlled studies of people who do a diet, they're compared against a group that didn't do the diet, and to see what the differences were. And to date, the only dietary change that's been shown to work in any way has been iodine regulation. And that's been shown to be effective for 78% of participants, like radically effective. A lot of diets are popular, they're talked about, gluten-free diets, AIP diets, others. If they've helped you, that's fine. These things have been studied. Gluten-free, the correlation is just that a lot of folks with celiac have thyroid disease, many overlap. But studies have been done looking at those who are newly diagnosed with celiac and comparing the rate of thyroid onset in those who did go gluten-free and those who didn't. It didn't change anything. There have now been 2 studies done on AIP diets and thyroid disease. The most recent one showed that it actually raised thyroid peroxidase antibodies. And the researchers in the study, they said that we think the antibodies went up because they might have raised their iodine intake. Like, well, if that's what matters, then do that. Do that thing if that's what works.
Yeah, because we hear, especially in functional medicine, about diet and gluten-free with autoimmune disease, including Hashimoto's. But it's interesting. Again, as you said, in some people works, some people it doesn't, and doesn't make much difference.
So you can go, and one approach is to say, well, I'll just try everything and see what works for me. And you could do that, or you could let somebody else go first. And think about like buying a pair of shoes. You look at consumer reviews. You don't buy 50 shoes and hope that eventually you'll like one. You look at the consumer reviews. Which one's got 5-star ratings? So that's clinical trials. Let someone else go first. See what worked most of the time for most people. That's going to give you the best odds.
What about, so continue on Hashimoto's, does anyone outgrow and treat completely? You see one day positive and after a few months or years, they are back, no antibody levels negative, or there's not high or elevated. Is that a possibility? Do you see that?
Of course. Yeah, that's been well documented. That's not uncommon.
That's great.
Well, the weird thing is that we should pull apart Hashimoto's and hypothyroidism. So most people that have Hashimoto's in some degree of hypothyroidism, the hypothyroidism is not relevant. It's not actually affecting their symptoms. It's not that big of a thing. And having Hashimoto's, you've got a lot of disease risks, you've got a lot of health risks, you've got a lot of symptoms. Surprisingly, there's very little difference in how likely you are to get bad thyroid disease. It doesn't change it that much. So if you take a group of people that have very high levels of both measurable thyroid antibodies and you watch them for 9 years, their odds of getting overt hypothyroidism are somewhere around 30% over the course of 9 years. Now, if you take that same group of people that has negative thyroid antibodies, their 9-year risk is about 11%. So if you break that down per year, you're talking about a 2.7% risk per year versus about a 1% risk per year. So if you've got thyroid antibodies, it doesn't mean your thyroid's going to shut down.
Yeah, true. Yes. Again, I had another question from this male patient, a young man, 20-year-old with recent diagnosis of Hashimoto's and normal thyroid function test, but then he has symptoms of severe fatigue and tiredness and hair loss or hair shedding. So what is the recommendation if we think with all these symptoms, is there any way that we can help him, or does he need other tests or investigations?
Yeah, so ideally one would have thorough tests. There's the overall autoimmunity, which sounds like is already there, that can cause these symptoms. The other consideration is there's a lot of comorbidities. There's a lot of other real medical illnesses that are more common in someone who has thyroid autoimmunity. And they can also be factors causing symptoms. So in a perfect world, you would be well screened for those sorts of things. But knowing autoimmunity is there, that's worth addressing. And that can cause all these symptoms that you described.
Mm-hmm. Yes. Now, what about thyroid nodules? Again, a lot of questions of nodules, a lot of incidental finding on ultrasound, we see them, and a lot of women in middle age we see with thyroid nodules. So the question, is there a risk of cancer with these nodules, and do we have to treat them, or we just monitor? So what do we normally do, and how they come, where they come from?
Yeah, the last one is easiest because they're just errors of cell growth. They're just cells that aren't growing right. There's random lumps of thyroid-like tissue, and they're just crazy common. You know, I'm 55. My odds of having a nodule is about 55%. Yeah, if you're 60, your odds are about 60%. It's pretty close approximation to your age and years, believe it or not. So yeah, crazy, crazy common. As far as if they need to be treated in some way, there's a whole degree of their size, their characteristics, how worrisome they look, whether there's calcifications around them. So that's something between someone and their doctor, their radiologist. Many do warrant treatment. Most do warrant simply monitoring, simply watching. In terms of can they be cancerous, any one nodule has about a 2 to 7% risk of harboring thyroid cancer. So they can. So they're important to stay on top of. And thankfully, for those to whom monitoring is a safe option, there's a lot of lifestyle methods that can make a big difference for them.
Yes. What about goiter? So again, a lot of comments about diet, how we can treat these people with goiter. Do we have to give them special diet? Have to refrain or avoid some certain foods like broccoli, cauliflower we see, or do we have to replace, if they have iodine deficiency, replace that iodine? So many questions.
Yeah. So goiter secondary to iodine deficiency,
Yes.
that's happened. There's been about 6 documented cases in the last 40 years. So it does happen, and that's in the US, that is. So it does happen, but that's not the most common cause anymore. It's a pretty rare cause. Mm-hmm. In most cases, there's not a simple discernible cause. In many cases, they're secondary to either Hashimoto's or Graves'. They can correlate with autoimmune thyroid disease. And in those cases, managing the autoimmunity is the mainstay. The risk for goiter is highest relative to tobacco and alcohol use. Those are large drivers of that. And obesity is also a large driver of goiter. In terms of documenting iodine deficiency, those types of cases I mentioned, that's mostly known by dietary intake. And it's pretty unusual diets that cause that because, again, iodine's in so many foods. So if a diet is almost exclusively raw fruits and vegetables without any sort of salt or sea vegetables, like just that, like no other animal foods, not even any processed foods, then one could consider that being a factor. But that's pretty rare. In most cases, it's a matter of managing autoimmune thyroid disease, minimizing the risk factors, and managing body weight if weight's an issue.
Yes. What about supplements? Do you have any supplements to recommend for thyroid health? Like we hear a lot about selenium. So any thoughts or suggestion on supplements?
You know, you were waving that book around earlier. I spent about 1.5 years just going exhaustively through any medical study you could find about diet, lifestyle, things in thyroid disease. Pretty much, not exaggerating, I pretty much read them all and read all the references. And my goal was looking at foods and diet, but I would always stumble across other things about nutraceuticals or phytonutrients or whatnot. And I was really impressed by that. There's actually a lot of good data about things that can make a huge difference. And it really hadn't been incorporated into existing products. So yeah, I did make a line of items for that purpose. There's good data about nutraceuticals lowering antibodies, helping nodules shrink, helping benefit many complications of hypo or hyperthyroidism. So yeah, they can make a very big difference.
So it's worth to read, everyone. What about stress? So especially during pandemic and lockdown, COVID times, high levels of cortisol and stress, there was so many people with diagnostic thyroid disease, subclinical hypothyroidism, or Hashimoto's. So in these cases, if there's even a mild hypothyroidism, with very high levels of stress, would you first address that stress and cortisol, or you treat thyroid, or both?
Funny thing, I'm glad you asked that. There's a funny thing that goes around in natural medicine about which do you treat first, the thyroid or the adrenals? And I hear that stated, and I almost imagine like in a movie where they got a bomb to defuse, like, do I cut the green wire first or the red wire first? If you do the wrong one, it's all going to blow up, you know? So where that came from, there's warnings on thyroid medications saying that these can't be used in the cases of adrenal insufficiency. And that got this idea out that, oh, wait, but if it's the adrenals, you can't do this, you can't do that. And the reality is, if someone has untreated adrenal insufficiency and overt hypothyroidism, if they have both, now to have both together and to be undiagnosed and untreated, that's like a few times per decade globally. That's not a common thing. But adrenal dysfunction is exceedingly common. So there's no magic wire you got to cut first, not this one or that one. If there's problems with either, you can address both, and you'll only improve how the body is working. Stress is not the body's friend. And adrenal dysregulation, adrenal fatigue is kind of a lame phrase, but adrenal dysregulation is a real thing, and it's a huge effect upon people's health. Yeah, and that was, of course, greatly worsened by the pandemic.
Yeah, many people affected. So what about thyroid disease and women? We see, of course, women, it's more than male patients. And why is it that we see more during pregnancy? Again, a lot of women in their 40s and 50s during menopause and transition. So there's more thyroid disease, and even thyroid nodules we diagnose during this time. Is there any link?
Yeah, a couple. So in general, the risk between women and men, a lot of guys out there have thyroid disease, totally happens, but it's somewhere around a 6 to 10-fold greater risk. And three reasons for that. A lot of the genes that I mentioned before are mostly X-linked on the X chromosomes. So women get 2 sets of X chromosomes. There's also ways by which fetal cells cause a microchimerism effect, which can cause a triggering of an autoimmune response. But a big part of it is hormonal changes. So we talk a lot about the body's whole endocrine system as this delicate chess game or this delicate orchestra, all these things that regulate one another. So when estrogen levels change, that causes a shift in thyroid binding globulin. And it also changes the body's tendency towards attacking the self or the non-self. So yeah, the rates of Hashimoto's are generally higher in women, but within women, the rates are 5-fold higher once they transition into even perimenopause. Pregnancy is also a big time in which the disease also starts up.
Yes, a lot of times myself treat pregnant women with low levels of thyroid hormones, so they need it during pregnancy. We see that very commonly. Someone is asking here, does breastfeeding affect thyroid results?
No. So breastfeeding itself doesn't, but back to a comment you just made, pregnancy is a time in which thyroid function changes a lot. So during and afterward, there's postpartum thyroiditis. There's a lot of ways in which during that time of life, thyroid levels can be greatly in flux. But just breastfeeding itself by variable is not thought to be one of them.
That's true. I've not seen that before. Someone is asking, how can they get the book? You can go to Amazon. I ordered it through the Amazon.
Yep. Kindle, Audible, hardcover.
Absolutely, yes. It's a great book, definitely. It's worth a read. Now, someone is asking about, I missed this. Yes, someone is saying again, because of pregnancy, was put on medication, and she's not pregnant anymore. Does she have to continue with that thyroid medication?
Yeah, this is a topic I'm so passionate about in general. So there's totally time and a place for thyroid medication, but most people that are put on them don't need them to begin with, and many that are put on them that don't need them long term are left on them long term. So some large groups of experts have argued that somewhere around 85 to 90% of people on thyroid medications should no longer be on them. And that's a strong statement because this is the top one, two, or three most widely prescribed medication globally. So yeah, most people, most trips to any pharmacy are not appropriate. And there's risks to thyroid medications for anyone. So they only should be taken if the benefits greatly outweigh the risks.
Absolutely. And what about, you're talking about stopping medication in some people who don't need it? Can we stop, or do we have to taper them off the medication?
Yeah, tapering's appropriate. And those last statements I made, they've caused a lot of follow-up studies on just that. You know, what does someone do if they're on them, they don't need them? How can they come off? What's the process look like? What are the odds of success? There's different levels of hypothyroidism, you know, mild, moderate, and severe. The severe ones are actually quite rare. And most of the studies that I'll talk about now had people from all of those levels. So the numbers are still good, but they're probably even better if you take out those that have the most severe hypothyroidism. But again, leaving them all in, they've shown that about 84% of people on medication can reduce their dose substantially, and about half of them can come off completely with no adverse effects when done in a proper fashion. The more recent studies did also include iodine regulation in that process. Thyroid meds are very high in iodine, and that's part of the vicious cycle on why they block thyroid function.
Very interesting. So thyroid medication has iodine in it.
T3 and the T4, those are all iodine atoms. Yeah.
Yeah, yeah. Someone is asking how long after taking the medication you can drink dairy.
Yeah, there's a general answer and there's a personal answer. So some things can cause malabsorption of thyroid medication for some people, even 12 to 16 hours later. And that can be dairy, that can be iron supplements, that can be coffee even. So some people, they've got to take their meds at night, or they've got to not do those things in the morning or at all. That happens. The average person can do about an hour gap on those things and do okay, but many can malabsorb unless those things are timed differently.
Okay, good to know. And my question is about low dose naltrexone. So we know naltrexone, of course, is a medication for many years used for opioid users, alcohol dependency. But we see nowadays a lot of lower dose of the same medications used for autoimmune, MS, Parkinson. And so have you seen studies or yourself experienced treating patients with low dose naltrexone for Hashimoto's, other autoantibodies, autoimmune disease, as well as we see again long COVID. A lot of people with long COVID taking it or being prescribed.
I have zero knowledge or training or research in long COVID. Let's put that out there. LDN and thyroid disease, yeah. So there's a lot of reasons why one could argue that it might work. And there's a lot of individuals that have taken LDN and said they've seemed to have gotten better. Again, I'm really interested in larger studies because a lot of folks get better anyway. And a lot of folks are doing 20 things. And which one of the 20 was it? You know, it's hard to say. So funny thing, but there was a documentary released in Norway about 8 years ago. And it made a very compelling case for low dose naltrexone being good for what ails you and like curing anything that's wrong, basically. And what happened was tens of thousands of people ended up taking it for several years. So some researchers said, hey, let's do an experiment from this. And if this is purported to reverse thyroid disease, the main claim was that it would cause people to need less thyroid medication. It would heal their thyroid, it would reverse the autoimmunity, and they would then need less medication. And many folks said, hey, we can measure this. You know, we can take a big bunch of people and we can just see how often they have to change their medication, raise it or lower it. And we can take another group of people that's pretty similar, also on thyroid meds, that's not doing low dose naltrexone, and let's just see the difference over this 3-year time period. And what they saw was that those taking low dose naltrexone needed more dose increases than those not taking low dose naltrexone. But there was no net benefit. They actually needed higher doses of thyroid medication while they were taking it. So
which
yes,
is not what we want.
no. So yeah, so this is kind of like the consumer reviews. What's most likely to work? Maybe that works somewhere for somebody, and maybe that 1-star pair of shoes is the ones you would like, but it probably won't be. You probably want to buy the 5-star ones. So yeah, it didn't get a 5-star rating from that study.
Wow, interesting. Someone is asking about supplements for Graves, if there are any support or supplements people with Graves' disease benefit taking.
Short answer to a lot of those, and not to push my own line, but take a look at thyroid specific formulations and either use those or look at those ingredients. I give detailed monographs for, there's a blend called Hyperthyroid Support. And there's a free monograph you can find on thyroidspecificformulations.com that walks through all the clinical studies on supplements helping hyperthyroidism. And yeah, so my trick was I just found all the good studies and used that. I just used those things in those amounts. But quite a bit of data about the right supplements helping the body more quickly lower thyroid hormones when they're too high, about cutting the risk for thyroid eye disease, about lowering the risk for cardiac complications, and preventing bone damage from hyperthyroidism. So yes, supplements make a big difference there.
Yeah. And someone is saying, I healed my hypothyroidism after taking pills for 14 years. That's great. Well done.
So funny story. Someone I talked to yesterday, a lot of what I recently started doing patient care again, which I'm having a blast with. A lot of folks need guidance on deep prescribing. And so I'll guide some people through that. And this last person that I saw yesterday, she's now off. She was on for 45 years on medication and she's doing fine. So yeah, some studies say that 4 years, after 4 years, it's difficult. I'm not seeing that clinically.
No, I haven't as well. I've seen people coming off without a problem after even many years of treating with. Someone is asking about palpitations and hypothyroidism, how to treat that.
Well, yeah, great question. So it's always, what's the cause? And hypo is this lack of thyroid hormones. And it occurs by degree. In the earliest stages, the body's making a louder and louder yell at the thyroid to work. And in the final stage, the thyroid isn't doing anything. At that final stage, hypothyroidism is clearly causing symptoms. And in most cases, you can reverse those symptoms by restoring thyroid hormone levels. But those final stages are actually rare. To be more detailed, that's a TSH well over 20, and that's T4 levels that are pretty much non-measurable. So barring overt hypothyroidism, in most cases, the answer is not adding in thyroid meds. The answer is more so identifying and managing the autoimmunity or looking at those other comorbidities. It can be a simple thing as like caffeine intolerance. That's common with those with thyroid disease. One could be low in magnesium. There could be any list of actual cardiac problems going on there as well. So yeah, that's a great thing to be working with a good diagnostician.
Yeah, especially mid-aged women more at risk with heart disease, so that they need an assessment. Someone is asking, what's the name of the book? The Thyroid Reset Diet. And you have another book recently.
It's my 8th, yeah.
The cookbook,
yep,
isn't it? The
first one's a cookbook. That was a lot of fun.
Wow. Yeah. I have to get that. Well, so I haven't read it.
The story was that when I wrote that book, again, I saw all these studies about phytonutrients, and some of them made sense to make thyroid supplements, but a lot of them were doing things that weren't thyroid related, and they were more so just dietary phytonutrients. There's so much data about just things we find in everyday plants having a wonderful benefit in helping our body regulate our hormones. So yeah, so the Hormone Healing Cookbook, like the top 5 hormonal symptoms and how do you make easy, tasty stuff in the kitchen to make a big difference with that.
Any spices, particular spices that you use for thyroid or reset thyroid disease?
Cardamom got a lot of attention in that book. That's a great one. Figs came up quite a bit too, as did pomegranates, beets, oats, onions, some very simple foods. Nothing too terribly exotic though.
Yeah, we keep hearing about pomegranate and beets.
Yeah.
Nowadays, yes, epinutrients they call it.
Fun little trivia is that so beets and their effects upon nitric oxide metabolism, their effects upon oxygen utilization. So they can raise an athlete's VO2 max by amounts greater than illegal steroids can, without safety problems, of course.
Oh, someone is asking, my TSH is 48 and doctor says no hypothyroidism. I have had symptoms for 3 years, weight plus hair loss, heart palpitations, and now noticing arrhythmia. How can I advocate for myself to get better?
Yeah, so that's a surgical procedure. That's called a doctor-ectomy.
That was the best.
Dr. Amin, have you prescribed that before?
Probably. During last 20 years, I had probably sometime, yes.
So a TSH that high, very briefly, either that's overt hypothyroidism, and it is clearly the cause of symptoms, or there's a thing called Ord's disease. There are situations in which I talked about the two more common thyroid antibodies. There's actually several others we can talk about and measure too. And some of the rarer ones, they block the efficacy of TSH and they cause it to falsely elevate. It still causes problems, but it makes the TSH not as meaningful. So yeah, that's it. But a TSH that high begs some explanation and some treatment.
Yes, very, very true. That's true. So someone's saying it's been 1 year. I have stopped taking Synthroid 88 after 15 years. That's great. Yes. So a lot of them really was unnecessary to begin with, probably.
Yeah, so given those levels, and this is the paradox, and this took me a long time to wrap my head around, I haven't heard this stated as much, but, I first started going to the A4M convention back in 95 when they started, they were very different then. It was a small group of a few hundred people, but there's been this idea that if you give someone a hormone that's chemically identical to what the body makes, and you achieve a blood level like found in a healthy person, that you've basically made that person a healthy person. Mm-hmm. And I haven't heard that really stated as much before, but I think a lot of us have thought that. And I probably used to think that, but I don't think that anymore. There's now a lot of data saying that when you take hormones outside the body, even if you're regulating the things we can measure, there's a lot of things that we can't measure that we know about. Things about like hormone conversion, receptor status, epigenetics or whatnot, cellular uptake. But below that, there's tons of things we don't know that we don't know about. Mm-hmm. And we see data like, for example, a large study out of Korea showing that those on thyroid meds with stable levels compared to exacting groups of people with the same sorts of medical risks, but not on thyroid meds, the death risks are twice as high. And we see tons of similar data about other hormone applications. So so taking a hormone is not the same as making a hormone. And when the body can do it by itself, that's always a superior outcome.
Absolutely. I totally agree. 100%. And someone is asking, how do we know if we are absorbing medication the right way?
Yeah, simple thing. So malabsorption of thyroid medication is talked about a lot. It's quite rare, actually, even in folks that have a lot of bowel damage. But in many cases, medications are poorly formulated, or especially if they're compounded, they may not be what they're supposed to have. The simplest thing is, I shouldn't do all the math right now, it would take too much time, but you can easily know how much medication you would need per your body size. The ballpark is about 6 to 8 tenths of a microgram of T4, and 100 micrograms of T4 is about a grain of natural thyroid, so about that much per pound of body weight. There's a lot of variation that you can be more specific based on age and gender, but if the dose you're taking is way more than what you would need if you didn't have a thyroid, your levels are stable and not excessive, there's something wrong with the medication, the absorption, the timing, the testing. But that's how you would know about that first.
Yes. So I think we have to probably end our meeting tonight. Thank you very much. It was such pleasure having you here, and hopefully to see you in person sometime soon. And yes, so everyone, thanks all the viewers. You can follow Dr. Alan Christensen and learn a lot. I learned so much from all the videos, and your website, podcast is amazing.
And Dr. Amin, you're doing a great job and sharing wonderful content as well. I'm honored here to be with you.
Thank you. Thanks a lot. Have a great night.
You too.
Bye-bye.